Thank you very much. Thank you, Valentina. So I'm Sophoclis Alexopoulos. I'm the Chief of Transplant at UC Davis. I'm going to be speaking about liver transplantation for Wilson disease. I wanted to start talking about a brief history of Wilson disease. And Wilson disease is slightly more than 100 years old as far as our understanding of it goes. And on the left, you can see the initial manuscript that was written by Kinnear Wilson describing the constellation of symptoms that we now know as Wilson disease. And it wasn't until 30 years later that we really understood that copper was part of the driving force of this disease. And initial medications the initial medication penicillamine was described another 15 years later. And by 1968, there was a very important publication that spoke about how adequate treatment with penicillamine could prevent Wilson disease development in patients who had copper overload. In 1971, the first liver transplant was performed for Wilson disease by Tom Starzl and his group. And by 1993, we understood that the ATP7 gene was identified as the cause of Wilson. So this is all within the past 120 years, which is pretty amazing. When we think about how Wilson disease presents, there are hepatic, neuropsychiatric, and other manifestations. So the hepatic manifestations include an enlarged liver, fatty liver, and abnormal liver function tests. You can have portal hypertension, which we talk about as elevated pressures in the veins that are draining the intestines that lead to a group of varices, abnormal venous connections between the veins that are draining your intestines and your heart. An enlarged liver, low platelet count. And when the liver decompensates, you can have ascites, which is fluid buildup in the belly, hepatic encephalopathy, jaundice or yellowing. From a neuropsychiatric standpoint, the neurological symptoms can include tremors, dysarthria, ataxia, dystonia, and Parkinson's type symptoms. And you can also have psychiatric mood disturbances, personality changes. And other manifestations that we also look at are Kaiser-Fleischer rings, which are abnormal deposition of copper in the eye, renal abnormalities, cardiomyopathies, and whatnot. So when we think about what are the indications for a liver transplant, we have hepatic indications, which are pretty well agreed upon, and those include end-stage liver disease or cirrhosis, where there has been chronic damage done to the liver that is so extensive that the liver isn't going to recover from it, and a patient's life is at risk. We can also think of acute liver failure, where there's been a sudden and very large amount of damage done to the liver where we believe that it's not going to recover and a patient is at risk of dying. There's also, when we look at other indications, such as inadequate medical treatment. And why might somebody have inadequate medical treatment? It can be either due to limiting side effects that are preventing somebody from being able to take adequate treatment, or from noncompliance. And then there's also this idea about neurological indications for liver transplant and Wilson disease and progressive neurological decline. When we look historically at mortality in Wilson's disease, there was a scoring system which was initially described, and that's the Nasr system. And if you look at this, it has some components that we use even today. So like bilirubin and a measure of coagulopathy. But what we really use nowadays is something called the MELD system, which is the Model for End-Stage Liver Disease score. And this is a calculated score, and it ranges from 6, which is normal, to 40. And the components of the score include your bilirubin, which is a measure of how jaundiced or yellow you are, your INR, which is a measure of how coagulopathic or how well your blood is clotting, your creatinine, which is a measure of how well your kidneys are functioning. And also nowadays we use the albumin, and we use gender as well. And the advantages of the scoring system are that it's objective, reproducible, reliable, and discriminate for predicting the risk of dying from cirrhosis. When we think about how livers are allocated in the United States, how can you get a liver transplant in the United States? You're placed on a list based on your blood type, and the list is rank ordered from highest MELD score to lowest MELD score based on the likelihood of somebody dying without a liver transplant. Now, the first patients that are on the top of the list are the status 1 patients, or the fulminant or acute liver failure patients, the patients who have the highest risk of dying, and then it's by descending order. When we look at survival after liver transplant for Wilson disease, one of the largest studies that's been very well done has been the French study, where the French Liver Transplant Centers accumulated all their patients with Wilson disease liver transplant. And these are the results from the study that was reported from 1985 to 2009. During that time period in France, there had been 121 liver transplants for Wilson disease. 53% for acute or subacute liver failure, 41% for decompensated cirrhosis, and another 6% for severe neurologic Wilson. And when you look at the outcomes that were reported, the best outcomes and the longest survival was for patients who were transplanted for chronic liver disease. There was a higher risk of death in patients that were transplanted for fulminant Wilson disease, and the highest risk of death was for patients who were transplanted with neurologic. This is the United States experience with liver transplant for Wilson disease. And this is between 1987 to 2016. You can see there were 156 pediatric patients and 515 adult patients that were transplanted. And the patient and graft survival at 10 years was around 84%, which we would consider in the liver transplant field very good. Liver transplant's it's a big operation, has a lot of complications. You can have both systemic complications like acute kidney injury, kidney failure. There are a lot of infectious complications that occur in about 10 to 15% of patients. You can have complications when you connect the blood vessels together that occur in about 10 to 15% of patients, and complications that occur when you connect the bile duct back to the intestine, which also occur in about 10 to 15% of patients. And when we look specifically at what the complication rates are for patients with Wilson disease that underwent liver transplant, and this is based on an Italian study which captured all patients that were transplanted for Wilson disease in major Italian medical centers between 2007 to 2018, you can see that the overall complication rate is pretty high. So this confirms what we have already seen based on data for all patients with liver transplant. And there's also a non-adherence that happens, because when we do a liver transplant, patients have to be on immunosuppressive medications to prevent their livers from being rejected for the rest of their lives. And if you stop those medications, you don't take them on time, that will definitely precipitate rejection. So when we look at a specific liver transplant for neurological symptoms, there is some data on this. I think the most robust paper was a subsequent analysis from the French data. And what you can see is that here, 18 liver transplants were done for neurological Wilson disease. And this is, once again, from the National Registry from 94 to 2016. The median age at transplant was 18 years old. With a range of 16 to 20. So these are younger patients that are being transplanted for neurologic Wilson. 44% of them showed major improvement. 22% of them showed moderate improvement. 11% showed stable disease, and 22% of patients died. So when we think about liver transplant for Wilson disease, I'm reminded of this. This has been a quote that has been attributed to John Walsh, which is copper, not too little, not too much, but just right. And with liver transplant, I would also say not too little, not too much, but just right. Because although liver transplant cures Wilson disease, it carries significant risk and requires lifelong immunosuppression, and we're always balancing risks and benefits. Thank you very much.